So first of all, thank you to the organisers for the opportunity to speak today. I think this first session has been really fantastic, really interesting talk. So I hope the rest of the afternoon will be just as interesting. And I hope you find this talk interesting, which is shifting from bacteria to viruses. So I'll describe, why is this not going forward? Okay, so I'll describe what we did. So we were having discussions in the early days of the pandemic around this question which Julian raised earlier, and was actually my question to him about COVID and subsequent sepsis. So there is this recognized association between subsequent bacterial disease following on from a viral infection. And the most commonly recognized version of that, as it were, is an influenza infection followed by a pneumococcal bacterial infection. So a small group of us were discussing whether or not now, because of COVID, we might indeed see an increase in invasive bacterial disease. But equally, countries were putting in measures to contain the spread of SARS-CoV-2, which is, of course, a respiratory virus. And so perhaps we'd actually see decreased invasive bacterial disease. And then whatever was to happen, we probably should expect that there would be these perturbations that would occur as containment measures are lifted. And so we were particularly interested in addressing this question, or these questions, around three bacterial organisms. So the first is Streptococcus pneumoniae, which we also refer to as the pneumococcus. The second is Haemophilus influenzae, and many of you will have heard about Hib, so the serotype B version of Haemophilus influenzae, and also meningococcus, or Neisseria meningitidis. And all three of these bacterial organisms are leading causes of invasive disease, which is life-threatening. So we're talking about meningitis or septicemia, the sepsis that Julian referred to, and also bacteremic pneumonia, so more severe pneumonia than just the respiratory infection itself. And so we were interested in these organisms, but I need to also point out that actually these organisms reside in the nasopharynx, and predominantly in the nasopharynx and to some extent the throat of healthy children. So that's the ecological niche, that's how these organisms are transmitted, and we've known this for a very long time. This isn't new, but the point here, which is relevant to iris, is that they are indeed transmitted via respiratory secretions, and of course we're in the midst of a pandemic due to a respiratory virus. So I'll get to more of this organism in a bit, but we included Streptococcus agalactiae, or Group B streptococci, as effectively a control organism. So Group B streptococci is also a leading cause of life-threatening invasive disease, and in particular neonatal disease. So Group B strep is carried in the normally healthy female gastrointestinal and genital tract, and therefore pregnant mums and their babies are at risk of Group B strep if the mother is carrying Group B strep disease. So this is also very well known, but the point here relative to iris is that Group B strep is not a respiratory pathogen. And I'll come back to that again in a minute. So we set up what we call the Invasive Respiratory Infection Surveillance, or the IRIS initiative, with a very straightforward aim, and that was to assess changes in the incidence of invasive disease caused by these four organisms I just mentioned. And we did this by assessing cases that were being referred to national reference laboratories, which were already part of their national system, surveillance system. So in other words, these are systems which have been in place in many cases for many decades, and normally receive these organisms in large part because they're notifiable diseases. So if these organisms are recovered from invasive samples like the CSF or blood, they're by law, they are required to report them to national reference laboratories. So we were able to use existing networks of surveillance and reference laboratories to set up the IRIS initiative. So this all came about very quickly, as many of us experienced in the early days of the pandemic. So the WHO declared the pandemic, if you recall, back in March last year. We started having our discussions, we started recruiting laboratories in about April time, and in a span of about 6 weeks, we had recruited 37 national laboratories to IRIS. We collected the data right from the start. We then submitted our first paper to medRxiv in November last year, and then we've published this work in May of this year in the Lancet Digital Health. Data collection is ongoing, and so this is very much a prospective study. Now, we recruited our centres largely based on the fact that this was happening in the early days of the pandemic, when reference laboratories were, of course, very stretched by COVID. Many of the laboratories were testing for COVID, or if they weren't testing for COVID, some of their lab staff had been seconded to other labs. So this was obviously a tricky time to be setting up a study, as many people recognize. So what we did is we contacted friends and colleagues that we knew had these surveillance systems in place, were part of our networks already, part of our collaborative networks and so on, and invited them to join. And it was a really fantastic recruitment, actually, because virtually everyone said, yes, we'd love to participate. And there were only 2 or 3 labs who said, we'd love to participate, but we just can't because of COVID. We're just not in a position to do that. So that's why we see the distribution of centres that you see here. So we are predominantly in Europe, also including Iceland. Canada is involved, Brazil, Cape Town, South Africa. What do we have? Israel. In the east, we've got China, Hong Kong, and South Korea, and then New Zealand. Just to say, we are expanding ever so slightly, so we're adding a few more centres to this, but at the moment, this is the centre of the IRIS network. So again, because we were in the midst of the COVID pandemic, we kept this very, very simple right from the start. So we set up a private database using the PubMLST platform and infrastructure, which I'll show you in the next slide. We initially just requested very minimal data, that is the cases of invasive disease and the date the sample was taken. And then we could make updates to those data records later. We set up the database such that the data entry could either be by the participants themselves, they could log in and enter their data, or they could send their data to us and we would enter the data. So the database is set up as a private database, which is part of PubMLST. So my 2 long-standing collaborators, Martin Maiden and Keith Jolly, and I have a Wellcome Trust grant which funds the infrastructure for PubMLST. PubMLST as a set of databases now contains almost 130 publicly available open access databases of a whole range of different organisms, predominantly bacteria, but a few others as well. We have a large international team of curators that curate the data that go into PubMLST. And over the past, well, about 10 years or so, we've been increasingly adding genomes to PubMLST, and we now have 620,000 assembled genomes with the associated metadata, all of which are publicly available. And then there's a whole suite of tools for analyses and curation and so on. So it was within the infrastructure of PubMLST that we then set up the IRIS database, because we can set up private databases as part of that. So it was important for the IRIS data to be kept private because these are reference laboratories. And indeed, in some of the cases, for example, if a country is collecting meningococcal data, they may not have that many cases of meningococcal invasive disease in a year. So by knowing the date of sampling, the region in which they live, and an age, you might be able to identify that patient. So it's very important for our labs that these data are kept private. We don't collect any patient identifier information per se, I should say. The laboratory that submits the data to us, to IRIS, retains full ownership of their data, and so we publish as a consortium of co-authors, as it were. And as I say, there's no identifiable patient data included in IRIS. So, as it stands now, we have 37 laboratories in 26 different countries and territories, which are submitting data for one or more of those 4 pathogens. One of the things that we discussed quite early on is whether or not we would see changes in their surveillance programs because of COVID, so reduction in sampling and that sort of thing. And it's important to keep in mind that the invasive infections like this, meningitis or bacteremia, are indeed medical emergencies. So these are patients who will almost certainly be treated in hospital and not at home or through a GP surgery. And as I mentioned earlier, the clinical microbiology labs are generally required by law to report these invasive infections due to the 4 pathogens that we're talking about. So the first data analyses were from the time period from the 1st of January 2018 through to 31st of May last year. And as I mentioned earlier, this is published in The Lancet Digital Health. So the first big finding was that rather than seeing invasive disease increasing as a result of COVID, we actually saw the exact opposite. And in fact, invasive disease was plummeting in the early months of 2020. So here I'd like to give credit to Melissa Janssen from Rendsburg, who's a postdoc working in my group, and she has created the figures over the next few slides to depict the data that we have. So what we're looking at here are 4 graphs, one for each of the different organisms. We're looking at a cumulative isolate count on the y-axis, and then we're looking at time since the start of the calendar year, measured in ISO weeks. We have the 2018 and 2019 data and these hashed lines here, and then the 2020 data is in the solid line. And this red vertical line is the week 11, which is when the WHO declared COVID-19 to be a pandemic. And that's important, as you see over the next few graphs. So you can see we've got over 62,000 data records for pneumococci, nearly 8,000 for Haemophilus, nearly 6,000 for meningococci, and then just over 4,000 for the group B strep data. And I think it's very easy to see that right around the time that the WHO declared COVID to be a pandemic, we see this plateauing of disease for all three of these organisms, but not for group B streptococci. And this is why I said we included this as a control to test whether or not the laboratories were indeed receiving samples as they expected. They all said that they were. They were receiving other organisms as well. So we didn't think that this change in 2020 was indeed down to lack of sampling, because other organisms were being received as per normal, and so there was no difference here. So we saw that there was this invasive disease reduction, and we said, well, why would that be the case? It was quite obvious this was happening right around the time the WHO declared the pandemic. So what else happened at that time? Well, of course, countries were imposing different containment measures within their countries. So we collaborated with Thomas Hale. He's running a very large group of over 100 students and staff in Oxford at the Blavatnik School, where they are collecting data on different indicators, now 20 different indicators around containment measures, in over 180 different countries. So we used in our data the OxCGRT stringency index. So here they collected data on schools, whether schools were closed and whether workplaces were closed, whether countries were cancelling various public events, large public events, whether or not the size of those gatherings was being restricted, whether public transport was closed, what the stay-at-home requirements were all the way up to lockdown, like we experienced and many countries experienced, and then whether movement was restricted both within the country as well as abroad. And in each of those cases, they would classify those on this range of values, and then they used an algorithm to combine that into a stringency index. And that stringency index then ranged from 0 to 100, and 100 means then a very strict policy of containment. And here, if we look at the data by color, this is, you can't quite see it, that's March 31st last year, 2020. And you can see that virtually the entire world is blue or dark blue, meaning that they had very stringent, each country was imposing strict containment measures. And this was true virtually everywhere in the world. If we then fast forward a year and we look at the 31st of March this year, you can see that that's actually changed quite a lot. So now we still have some countries which are in blue and dark blue colors, but there are more countries that are in this sort of middle range of stringency, as it were. So we use these data, the stringency data, which could be calculated then week by week, and we superimposed, again, this is Melissa's magic for these graphs. I'm showing you 4 countries here. In the next slide, I'll show you all the countries. But basically superimpose the stringency index in the background for each of the cumulative curves for each of the different countries. So I'm showing the pneumococcal data here. So for example, England, it's a cumulative curve like you saw earlier, but this time just for England, so just over 12,000 isolates. Again, the 2 previous years, 2018 and 2019, and these are the 2020 data. And then you can see that leading up to where this starts to change, slightly differently, but leading up to where it starts to change, we start to see more stringent containment measures in place. So again, the darker blue colors. In Finland, much the same, went into moderate ranges of stringency, but that coincides with this curve. Similar for France and also for Germany. And if we look at this across all countries, I realize you can't see each individual country, but I think you can appreciate that the pattern is very similar. So in some countries we have quite small numbers of isolates. Iceland is a small country anyway, but you can see that the pattern is quite similar. So the point being that when the pandemic was declared in week 11, countries then imposed some form of stringency measures, containment measures within their country. And despite the fact that those stringency levels varied country to country, you'll recall that Sweden got a lot of criticism for not having more stringent measures, and yet their data look very, very similar. Finland and Denmark here look very, very similar as well. So despite the fact that there were differences in stringency levels, you saw this reduction in invasive disease in all countries. Again, this is pneumococcal data that we're showing here, but in the paper you can look at the Haemophilus and meningococcus graphs, which look very similar. So we had discussions then around, within the IRIS group, around how else we might explain it. So in countries where there was less stringent measures versus, say, the UK, where we were in strict lockdowns, then how else might we explain the similar patterns that we see? And so we went to the Google mobility data. So Google created these COVID-19 community mobility reports, which are basically the device location history data, all tallied by Google. And they did this country by country, unless countries were small, like Iceland, where you could potentially identify someone, or in China, Google is censored. So we don't have data for those two countries. But otherwise, for countries, they were collecting the mobile history data for 6 different categories. And we used the residential and workplace data to look at our data in combination with the IRIS data. Now, what they're doing is calculating a daily mobility data value, which is the percentage change from the baseline day. And that baseline day was the median value of movement based on the 5-week period in the first 5 weeks of last year. So everything's being compared to those first 5 weeks, sort of pre-pandemic-ish, as it were, and then comparing that to the more recent data. So again, Melissa created some very nice graphs which capture quite a number of different types of data. Here we're looking at the workplace data and the residential data. The dashed line, vertical dashed line, is again week 11 when WHO declared the pandemic, and then daily data over this period of time from the beginning of 2020 onwards. So what you can appreciate is, again, that there's a lot of similarity amongst each of these countries. Oh, I should have said that Google does not disaggregate the 4 nations within the UK, whereas we do in IRIS. So here we've lumped that back together for the UK. But you can see that all of these countries look relatively similar, that things look more or less like baseline, as in the movements between workplaces and residential locations is more or less what you'd expect prior to the declaration of the pandemic. And after that, people spend more time at home and less time at work. And that's true for all the countries. So although Sweden was not in full lockdown, they too saw more time spent at home and less time spent at work. Just one final point, these data spikes look a bit odd. It's because there are, these are daily data. So when we have weekend data or indeed holiday data, so in Easter time, then we see this much bigger spike. But here the main point was that despite whatever the countries decided to do in terms of stringency of containment measures, human behavior was also important. People were making their own choices about whether they were going to be at home or in workplaces, at least to some extent, which would help explain the patterns of similarity that we see across these countries. So that was great, and we wanted to then try to quantify some of the changes that we saw. So this work was led by Professor Noel McCarthy, who used to be here at Oxford. He's now at Trinity College in Dublin, and also by David Shaw, who's a DPhil student in my group. So we set out now, as I said, to quantify the effect of these containment measures on the numbers of cases. And so we were going to do this then after there was this implementation of containment measures to try to understand what happens after that period of time. And so they assessed the evidence for both a step change and also a slope change in terms of the number of cases per week. And then focusing specifically on pneumococcus, because we have such a large volume of data, they then performed a meta-analysis to summarize the changes that occurred both 1 month and 2 months after this interruption. And just to depict that here, so what we're talking about is time over the x-axis and then some sort of outcome here in terms of disease. We have some level of invasive disease prior to the intervention. Then we have this intervention, which is the containment measures. That creates the step change, and then we get a change that occurs subsequent to those interventions, and that's the slope change. So in order to define that interruption time point, they decided to use the Google Workplace mobility data. And so they selected this interruption time point for each country to be the week that contained the day, which was halfway from that baseline level to the new lower minimum value. I said that we didn't have data for Iceland because it's a small country, so they used the modal week of other European countries. Also, we didn't have data for China, so the week, which was week 5, was based on news reports of different policy decisions. And so in the end then, the intervention week for each of these countries was for China, Hong Kong and South Korea, it was weeks 5, 7 and 8. For New Zealand, it was week 13. And then for all the other countries, it was either week 11 or week 12. So when that intervention occurred, which then resulted in a step change. Also controlled in their model for seasonal variation. So we had 3 countries which were in the Southern Hemisphere, Brazil, South Africa and New Zealand, and the rest were in the Northern Hemisphere. And of course, we wondered whether there would be differences that might appear as a result of the 2 different hemispheres. They combined the data across all the countries for all 3 pathogens and limited those analyses to the countries who did provide data for all 3, pneumococcus, Haemophilus and Neisseria. And then they focused in on Streptococcus pneumoniae because we had so many cases, over 62,000 cases. And in the pneumococcal analyses, they then focused both on country-level analyses, that we could look at patterns that occurred across the countries and compare countries to each other, but then combined the data as well to assess the effect of interventions. So school closures were an important intervention. These organisms, as I said in the beginning, are all carried by young children. So one question was whether it was the school closures that was indeed interrupting transmission, whether that explained the data that we saw. So the models estimated that overall the changes that occurred as a result of the COVID pandemic led to this 38% decrease in the incidence of pneumococcal invasive disease that followed just after that interruption, so that's step change, and then a weekly reduction of about 13% on average up to the end of our first assessment period, which was the 31st of May. So that's that slope change. They didn't see any different patterns across the different regions of the world. So in countries generally looked very similar in terms of these analyses, and there was no difference based on northern versus southern hemispheres. And also there was no evidence that the data that we saw, this reduction in disease, was explained by school closures. So school closures did not significantly improve the fit of the model. And finally, they then calculated the incident rate ratios per country and overall. And you can see in this first set of ratios that we have a 68% reduction in the incidence of invasive disease 4 weeks after that interruption. And by 8 weeks, a decrease of 82% in terms of an incidence of invasive disease. And that equates to about 6,000 lives, or 6,000 fewer cases of invasive disease in these countries in which we're sampling. So what do we see now? As I said, we're continuing to collect data. So far, there's no evidence for a return to what we might consider to be normal. So Mark van der Linde runs the Streptococcal Reference Unit in Germany, and he's one of the key organizers of IRIS. So you can see the German data here. This is the front page of our IRIS database, and you can see that the 2018 and 2019 data are in blue and orange respectively. This is what was happening in 2020 in terms of the reduction in disease, but you can see that across 2021 we're still seeing this very significant reduction in disease. And so we haven't yet seen this return to normal. For group E streptococci, this is again German data, again no difference. So there's no obvious explanation that the surveillance projects are in any way not running it as expected. And so we still are in this phase of seeing a reduction in invasive disease. But we expect that that will change. And so we're monitoring for that. So what we know at the moment is that all the countries in IRIS have experienced this significant reduction in invasive disease and a sustained reduction, even up to the present day. And we see no significant changes in group B strep, despite the fact that the control policies or the containment measures that were introduced in each of the different countries varied quite significantly from no lockdowns to full lockdowns. Despite that, we still see very similar trends in each of the countries. That resulted in this reduction of nearly 70% invasive disease at 4 weeks and 82% at 8 weeks following that week in which there was this interruption. And so overall, how would we explain this? Well, the most obvious explanation is indeed the fact that there is this reduced transmission of these 3 organisms, all 3 of which are also carried in the respiratory tract. The containment measures are very much focused on SARS-CoV-2 and a respiratory virus, but indeed those containment measures are having an effect on other respiratory pathogens as well. And as a result, then that has led to this significant reduction in life-threatening invasive disease. Now, besides the fact that that's important from a disease perspective, it also highlights the importance of vaccination. So, as I said at the very beginning, I didn't give you the statistics, but the global morbidity and mortality due to these three organisms, especially pneumococcus, is very high. But there are already safe and effective vaccines that are available for all three of these organisms. None of the vaccines that are available now protect against all types of these three organisms, but they are safe and effective and have a real impact in countries when they're used. There have been, as many of you will have heard, have been disruptions in vaccination programs. And so we are now somewhat concerned about the fact that the vaccination programs have been disrupted. Although disease due to these three organisms is significantly reduced, we expect that will change as containment measures are lifted. And it's not entirely clear what that will mean for both disease and the spectrum of disease that occurs. So, in summary then, the IRIS initiative was quickly established in response to this, the pandemic, and it's very much an international network and partnership. We've relied on these high quality surveillance programs, and that has been one of the kind of key factors, I think, in being able to do this quickly, because we had high quality data right from the start, and PubMLST facilitated this data collection. Now, I said we're interested in what's going to happen subsequent to this. So the next phase of IRIS, besides continuing to collect data, is focusing on genomics. And so about half of these laboratories will routinely sequence some or all of these organisms anyway, but we're working very closely. I'm working very closely with David and Paolo to develop a program in which we're going to be able to provide sequencing for all of these organisms, so that we can measure not just the incidence of disease, which we'll continue to do, but also look at how the population structure of these bacteria are changing. So some of that information we can get phenotypically. So for example, serotypes, or being able to characterize the pneumococci, can be done phenotypically, but we also want to understand more at the genomic level, and it's the sort of work that we do routinely anyway. And so being able to address the genomic epidemiology is going to be really important. It's possible that we see the same sorts of strains and serotypes for each of these organisms circulating again when disease starts to increase, but it's also possible that because we've effectively created this bottleneck, that a different sort of organism, that types of organisms emerge on the other side, different serotypes, which might affect vaccine coverage and so on. So there are lots of potential for change, and quite important change. And so IRIS is now very much in a good position to be able to spot those changes when they occur, and then start to address what those changes really look like, not just in terms of numbers of cases, but actually the bacteria causing those cases. So I'll finish there. The work is funded in part anyway by the Wellcome Trust, both with an investigator award to me, and then also, as I mentioned earlier, a biomedical resource grant to Martin and Keith and I for funding PubMLST. But there are lots of funders that are also involved in each of the local centres for providing the support that they need to do the microbiology that they need to do. And finally, just to say thank you to all 96 people who were on the first paper, all of whom are really important to the study, all of whom have contributed to making this possible, especially in such a short period of time within the labs, and being involved in data and so on. So I'll stop there. Thank you very much, and I'm happy to take some questions.